Welcome back to the Public Health Practice Gap. I am Dr. Bradley Fevrier, public health educator, consultant, and founder of NextGen Public Health Consultancy. This podcast explores what I call the public health practice gap, the distance between what research tells us works and what institutions actually implement in the real world. Because in public health, the problem is rarely a lack of evidence. The problem is that our systems are not designed to deliver that evidence at scale. Today's episode builds directly on this week's newsletter. The workplace is becoming a health system. That idea may sound subtle at first. You might think a workplace is an office, a warehouse, or a hospital floor, not a clinic. But this represents one of the most important structural shifts happening in healthcare today. Because whether we recognize it or not, employers are becoming public health institutions. In the next few minutes, we are going to deconstruct why the office cubicle or the remote workstation has more influence over your longevity than your doctor's office ever will. When most people think about healthcare systems, they visualize a specific map. They think about high-rise hospitals, neighborhood clinics, white coat physicians, and the complex web of insurance. That is a visible system. It's the system we turn to when things go wrong. But there is another system operating in parallel, one that is often invisible because it is so integrated into our daily lives. That system is the workplace. Think about the sheer math of human existence. For millions of adults, the workplace is the primary arbiter of their environment. It determines the sedentary behavior. How many hours are you chained to a desk? Nutritional ecology. What is available in the break room or the immediate vicinity during a 30-minute lunch break? Circadian rhythms. When do you wake up? And when are you allowed to sleep? Psychosocial stress. Is your environment one of the psychological safety or chronic cortisol spikes? In public health, we talk about social determinants of health, but we often overlook the employment determinant. These aren't just perks or job duties. They are the daily exposures. And in public health, daily exposure is exactly what shapes long-term outcomes. Let's look at the frequency of intervention. A patient may see a primary care physician 2 or 3 times a year for 15 minutes. In those 45 annual minutes, we expect a doctor to reverse 365 days of lifestyle. This is why the workplace matters more than we think. Conversely, an employee experiences the workplace 8 to 10 hours a day, 5 days a week for decades. This level of exposure creates environmental control over behavior. We like to believe in individual agency, the idea that you just need to choose to be healthy. But public health teaches us that environments beat willpower every single time. If your workplace culture demands 24/7 responsiveness, a meditation app subscription provided by HR isn't a health intervention. It's a band-aid on hemorrhage. Workplaces influence movement patterns, sleep quality, and even social interaction, the very pillars of health. Therefore, employers are already influencing population health, whether they intend to or not. They are practicing public health by default, often poorly. Let's look at a real-world irony. A large hospital system. This organization employs about 3,000 people. The entire mission is health. Yet, internally, leadership notices a crisis. Clinician burnout is at an all-time high. Sick days are mounting, and their own insurance premiums are skyrocketing. What is the standard institutional response? They launch a wellness initiative. 1. They start a step challenge. 2. They offer insurance discounts for biometric screenings. Or 3. They sent out an email blast about Mental Health Awareness Month. And what happens? Participation is moderate, but the needle doesn't move. Why? Because the intervention focused on individual behavior, not system design. The hospital was trying to wellness its way out of a broken operational model. The schedules remained grueling. The staffing ratios remained unsafe. The wellness workshop was scheduled during a time when no one could actually leave the floor. This is the gap. We are trying to fix the person while leaving the factory, quote unquote, that breaks them completely intact. So, let's apply the public health practice gap framework to the workplace. 1. The evidence. We have mountains of peer-reviewed data showing that autonomy, movement, and psychological safety reduce cardiovascular disease and depression. The policy. Human resource departments adopt wellness policies that look great on paper and on social media, for instance on LinkedIn. The operational reality. This is where the gap widens. Actual systems still prioritize short-term productivity and throughput above the biological limits of the human beings doing the work. Limited change. We have a transmission error between what the science says and how the manager manages. If the system producing the strain is never redesigned, the intervention is just noise. So, how do we address the program versus the infrastructure? This is the central thesis of our discussion today. Most organizations treat wellness as a program, but health is actually shaped by infrastructure. Let's define the difference. Programs are temporary, they are optional, and add-ons. They are the Yoga Wednesdays that you can skip when you are too busy. Infrastructure, on the other hand, is embedded, continuous, and non-optional. It is the default setting of the organization. Some examples. A step challenge would be an example of a program. It is temporary. A workforce designed movement, for instance, standing at a desk, walking meetings, those would be more systemic. That would be considered infrastructure. A mental health webinar is temporary versus a workload model that prevents chronic overtime and burnout, which is more systemic, which is infrastructure. Another example would be A nutrition email, that is temporary. That is a program. But on the other hand, an on-site access to high-quality, subsidized whole foods is an example of infrastructure. If the infrastructure doesn't change, the outcomes cannot change. We must stop asking employees to be resilient enough to survive toxic systems and start building systems that don't require superhuman resilience to stay healthy. So, we are moving towards a reality where employers are health system nodes. They control the 4 levels of public health, which is time, the environment, initiatives, and access. In the United States especially, the employer is the gatekeeper to the physician. But they are becoming more than just that. They are hiring chief medical officers. They are opening on-site clinics. They are negotiating directly with pharmacy benefits managers. When an employer decides to cover or not cover GLP-1 medications, for instance, or mental health parity, they are making a public health policy decision. They are no longer peripheral actors. They are the front line. Why is the shift happening now? Is it just because CEOs woke up and decided to be altruistic? It is the economic driver. Employers are finally realizing they are absorbing the staggering costs of the practice gap. They pay for it through 1. Direct costs, exploding insurance premiums. 2. Indirect costs, presenteeism, being at work but not functioning, and also absenteeism. 3. Replacement costs due to burnout and turnover. At a certain point, prevention becomes economically necessary. It is no longer a nice-to-have philosophical goal. It is a financial survival strategy. The gap isn't just a health problem. It is a massive, unrecovered business expense. This shift changes our jobs. If you are a public health professional, you can no longer operate solely within the walls of a government health department or a non-profit. We must move inside the institutions where people spend their lives. We need public health experts in C-suites, in HR departments, and in operations. We need to be the engineers who have transitioned these organizations from places that provide jobs to systems that provide or produce health. We need to be the engineers who help transition these organizations from places that provide jobs to systems that produce health. Our value is in translating that evidence-based research into operational reality. The future of prevention will not look like a standalone program or a grant-funded pilot. It will look like system design. It will be baked into how we structure the workday, how we incentivize managers, and how we build our physical and digital workplaces. When health is by design rather than by choice, we will finally close the practice gap. The most important insight from today's episode is this: health is not produced in isolated interventions. It is produced in systems. And the workplace is one of the most powerful systems we have. Next week, we take this one step further, because if employers are becoming health system actors, we need to ask a bigger question. What happens when hospitals are no longer the center of healthcare? That's where we're going next. If today's episode resonated with you, I encourage you to read this week's edition of the Next Gen Public Health Brief. The workplace is becoming a health system. You can find it at nextgenpublichealthconsultancy.com. If you found this valuable, share it with someone working, because understanding the system is the first step in redesigning it. New episodes of the Public Health Practice Gap are released every Tuesday. Please remember to subscribe to our newsletter and also listen wherever you receive your podcasts. I am Dr. Bradley Fevrier, and this has been the Public Health Practice Gap.